go.
Okay, thank you. So, hello everyone, and welcome to our online seminar today. What is new in the breakpoint table version 15? And I think this is like the 4th or 5th time we're doing this, and I hope it's going to be useful for everyone. So, we are 4 people in the breakpoint team. It's me, and it's Anna-Karin, and it's Ingvild. She can not be present today, unfortunately, and then Heikki. And today also Erika and Christian will be here to help answer all the questions you have. And in addition, Barbara is here as always, who is our chair of NordicAST. So we'll use the first hour to present the changes we have in the breakpoint table. And then the last half hour we'll do questions. And we'd like you to use the chat function. Just go on and start asking whenever you want. If it's something that needs clarification about what we're presenting, then Christian probably will just say, hello, I need some clarification. Otherwise, we'll take all the questions at the end. And it's important that you stay muted so that it's not unnecessary noise. And as always, we record this online seminar so that you can review it at a later time. Okay, so we'll start as always just telling you what you can get out of the NordicAST table that you don't get from the UCAST. And then we'll go through the changes. First, some general changes and no dosages, breakpoints and brackets, ATUs, topics. And then at the end, after that, we'll do all the species. Someone's not unmuted.
Please mute the microphones, everyone. Otherwise, it will be a disturbance in the recording. Thank you.
And please write questions. We love questions. Okay. So just to remind you, what does the NordicAST table give you that in addition to the UCAST? Well, we try to adapt to the Nordic countries. And one thing we do is we only use relevant agents. So even if there are breakpoints, we do not include in the table agents that are not used or available in the Nordic countries. So they're here marked in blue. I put in parentheses IV amoxicillin because I don't think any of the Nordic countries actually use it, but we still have it for many of our sheets. So we'll see if we also will take that away. We do not include any of the agents that have a dash, and then we only have a few agents with the IE. Then we have some comments that are marked in red, and those are comments that we only have in the NordicAST table and not in the UCAST table. And one of the comments we sometimes use is, for example, to remind you what to send to a reference laboratory. But there are no contradictions or exceptions from the UCAST breakpoints. They're exactly the same. And we also have a little different layout. So instead of using footnotes, we use the comments in the row next to the agent that we're talking about. And then we have translated the comments to the Nordic languages. So it's going to be easier for you to use. We have the same flowcharts as in the NordicAST UCAST table that is that we translate, but in addition, for the Swedish and Norwegian tables, we have the ESBL flowcharts both for the Enterobacteriales and the Pseudomonas. And then there are contact persons in each country. And we do like to get, if you find something you don't understand or something maybe not correct, then because even if we proofread, there's always a few mistakes. So we welcome you to send us emails. Another thing we have in the NordicAST table is our own, we have a few explanatory method documents. You see listed here. Last year we updated the ESBL AMP-C detection and also the Haemophilus. And then this year we'll do a small revision of the anaerobes, mostly with the inducible clindamycin, and we may do a revision of the CPE detection. Okay, so now to this year's breakpoint table, version 15. Both cefepime and metazobactam and estrinum avibactam both of these agents are added. For many of the, especially gram-positives, but also Haemophilus, we have added the cefepime and I don't know how to say that, and metazobactam, but it really doesn't give any clinical benefit with the inhibitor, just so you know. And we won't go through all this for every species, then you know this is added. Also, now, as in the UCAST table, we have a link on top of each sheet where you can click directly to the guidance documents. In the NordicAST table, we've had direct links for many of the comments where we have this in bold in the rows, but often it's a little when you click it and then you suddenly get to the UCAST guidance document without really meaning to. So we removed all these links, but we have the link on top of each sheet. And then there is we now emphasize that unless otherwise stated, breakpoints are valid also for special situations such as endocarditis and meningitis for relevant species and agents. So if there is no information, that means it's the breakpoint pertains to everything, all situations. And then you will have own rows for endocarditis and meningitis. And there's a note about this that I will tell you about. And then also there's a new guidance document on endocarditis that we have also included in the content sheet. So it's a new row at the bottom. A few notes. This is a new note, and it's just what I said about that unless otherwise stated, breakpoints are valid for all indications. So that's important to know. There are some revised notes. One is on the definition of infections originating from the urinary tract. And the new part is the one here in red, that we, first of all, emphasize that bloodstream infections except severe sepsis, because we do not want anyone to start oral therapy for severe infections, and that also comes here for oral agents. The breakpoints mainly apply to non-severe infections and oral step-down therapy. And then we have, under the abbreviations and definitions, IE, which is insufficient evidence. There the wording is quite revised from last year, and it also refers now to the guidance document where there are no breakpoints. This is a very good document, and it's newly revised in UCAST. And the other abbreviation that we actually took out of or removed from the NordicAST table last year because it was PK/PD breakpoints, and since these were no longer available, we took it out. But now we put in PK/PD cutoff values, and it just refers to the PK/PD cutoff sheet where you have quite a lot of information, which Anna-Karin will show you afterwards. So that was on the notes, and then just quickly on dosages. The wording in the heading on top is a little revised. And then in addition, now that there is a little box with information on UCAST breakpoints and dosing for challenging infection sites and on special situations for antimicrobial treatment. And you find that on the very bottom. When it comes to other changes, as always, a few new dosages and a few new comments, and maybe what is most important in the Nordic countries is the benzyl penicillin, where the high dose is revised, and also the comment. It used to be a very long comment with all kinds of situations, and now just one or two sentences, I think. Okay, so now I leave the floor to you, Anna-Karin.
Thank you, Karianna. I think we can go to the next slide straight away, talking about the breakpoints in brackets. Yes, so the species combination with breakpoints in brackets in the breakpoint table version 15, you can see all of them here. To the left, we have the old ones that we already know about. And for version 15, we now also have some new breakpoints in brackets. That goes for amoxicillin oral, other indications for both the Enterobacterales and the Enterococci faecalis, where the amoxicillin now is classified as an I within brackets. And the same goes for amoxicillin clavulanic acid oral for Enterobacterales and other indications. And then we also have a new breakpoint in brackets for some benzalpenicillin and Streptococcus viridans endocarditis isolates, but Karianna will tell you more about that later. Yes, we can go to the next slide, and this is just a short reminder about what the breakpoints in brackets actually mean. It means that you should report with a comment, not an I or an S, and the comment should include that you state that you should not use in monotherapy. Instead, you should use this agent with another active agent or an active action. And I think you all remember that in the UCAST table, this is not very clear in the comment sections, but this is one of the things you get in addition in the NordicAST table, where we actually try to explain exactly how you should be putting this comment together. Yeah, we can go to the area of technical uncertainty, and we have 3 changes regarding this in the breakpoint table this year. There are 2 new ATUs for the Enterobacterales and the new compounds Astrionam avibactam and the cefepime and metazobactam for the zone diameters breakpoints, and we also have an ATU for Pseudomonas aeruginosa and cefepime zone diameters. Then we can go to the topical agents sheet, and that is not very much that actually have changed in the content of this sheet. There has been a lot of technical updates, so it looks a bit more easily to read. But the only thing that actually changed here is the fusidic acid cutoff for Staph aureus. Yes, then we can continue. Could everyone please mute? Yes, as Karianna said, the PK/PD breakpoint sheet is now called the PK/PD cutoffs. So we actually thought that this sheet was going to disappear in the version 15, but UCAST decided to keep it. UCAST decided to keep it, but instead it's now called the PK/PD cutoffs, and that is a very good updated explanatory text regarding both why the PK/PD breakpoints were removed and also how you can use the PK/PD cutoff.
Sorry, Anna-Karin, I accidentally muted you. You unmute yourself.
Okay. I hope you mute the other ones who are doing coffee.
I was trying to do that, but then I accidentally muted you. Sorry about that.
Okay. Then let's go on with the cefiderocol, and then we have some news. We can go to the next slide. So for cefiderocol and Acinetobacter species, the comment is revised, and also the tentative clinical cutoffs in the comment are revised. So please read this with caution. And the same goes for the next slide, where we have cefiderocol and the Stenotrophomonas maltophilia, where the comment is revised, as well as the tentative clinical cutoffs you can use. And then we have a new slide with cefiderocol and a new comment also for Achromobacter psilosoxidans, which I think could be very, very useful in infections in patients with cystic fibrosis. So it goes the same way as the other cefiderocol comments, but the cutoffs are, of course, species specific. Yeah, we can go on. Yes, then we should take a look at the big gram-negative sheets. And the first one is the Enterobacterales, where we have 2 new breakpoints. for the Astrionam avibactam and the Cefepime and Mentesobactam. And we can go to the next slide where we have the only revised breakpoint for the Enterobacteriales, and that is the zone diameter breakpoint for ceftriaxone. And the amoxicillin and amoxicillin clavulanic acid oral other indication is now changed to an I in bracket, as I mentioned before. Yes. I also like to mention that for the Enterobacteriales, there's also a revised comment regarding reading instructions for azithromycin. And it states that when you are reading the azithromycin zone diameter, you have to take growth appearing as a thin inner zone into account. Yes. The next one. Could everyone please mute? Yes, then we will talk a little bit about the Pseudomonas species. And as Karianne mentioned, here we have the new antimicrobial of Cefepime and Mentesobactam, but that is only with a note and also with a comment stating that the inhibitor does not add any extra credit to this antimicrobial. So Cefepime is a better option. And for the monobactams, we have now added the Astrionam avibactam that is classified as insufficient evidence for Pseudomonas species, but could of course be a treatment option together with some other agent for metallo-beta-lactamase producing Pseudomonas species. Yes, we can go on to the Acinetobacter. We have a revised comment for the monobactams, stating that Astrionam avibactam is not a good compound for the Acinetobacter species. It should be reported with an R without prior testing, and the same goes for Cefepime and Mentesobactam. Then regarding the minocycline, which we might not use a lot in the Nordics, there's a new comment for clarification that the classification of insufficient evidence only goes for the intravenous treatment, not the oral treatment. Yes, we can continue here with the Stenotrophomonas maltophilia. And in this sheet this year, there are big changes. And I think you all know that NordicAST published a guidance document, which is very good, in November 2024. If you have not seen it, I really recommend you to read it. And according to this, new agents has also been added in the breakpoint table, and that is the Astrionam avibactam, the minocycline, tigecycline, ciprofloxacin, and levofloxacin. Yes, we can go to the next slide, Karianne. But we will start out with the revised breakpoint for trimethoprim sulfamethoxazole and the MIC-R breakpoint that has been changed from 4 to 2 this year. There is also a revised comment for cifiderocol, as I mentioned earlier, and Astrionam avibactam now enters the Stenotrophomonas sheet as an IE, insufficient evidence. And then we have the last slide, I think, with the other new agents, the fluoroquinolones, ciprofloxacin and levofloxacin, and the tetracyclines, minocycline, and tigecyclines. And for all of these 4 compounds, we don't have breakpoints. We have a note and a comment. And the comment is actually the same for all of these 4 antimicrobials, telling us that they have been used in combination therapy, and the ECOF of these can be used to exclude non-wild type isolates. Unfortunately, criteria for disc diffusion is missing, so you have to do an MIC testing. Yes, thank you. Back to you, Karianne.
Yes, just trying to unmute myself. All right. So now I'm Ingvild for a while, doing all her sheets, and there are quite a few things in these gram positives this year. We can start with the staphylococci. We have quite a few new comments, but they're really not new and unique. It's just that when it comes to the cephalosporins, for all cephalosporins, if you report that if they're susceptible, you have to use the I. It's a wild type. So we've just made sure that all the cephalosporins have this comment. And then when it comes to the carbapenems, and I think this was just something we forgot last year, is just to emphasize that when we have the combinations, imipenem, rilabactam, and meropenem, vaporbactam, that the addition of the beta-lactamase inhibitor doesn't give any clinical benefit. And then there's one thing you have to note, because this is a little contradictory to what we said on the workshop last year. It comes to the dalbavancin and also teicoplanin and telavancin. Because earlier or previously we've said that you can infer susceptibility from vancomycin, but it turns out that you actually can have resistance in vancomycin susceptible isolates. So this part of the comment for all three of these agents are now removed. And in addition, the dalbavancin breakpoint is slightly adjusted to 0.25. So that means you have to test for the one you want. So if you need dalbavancin, you have to test dalbavancin. So that was the cephalococcii, and then enterococci. Quite a bit of yellow this year. There are removed and revised general comments. One that we've had about referring to national guidelines for endocarditis. Since we now have specific endocarditis breakpoints, we don't need this anymore, this general comment. We have also revised the comment on the species for which the breakpoints are valid to, but it's just the wording. So there are no new or added or removed species. And then also removed the comment about inferring amoxicillin and piperacillin from ampicillin. I'll show you. And then there are several other changes, so you'll just have to read the table carefully. We'll go through most of these, that there are both new and revised breakpoints, new and revised comments. Also, according to administration, where you have IV and oral. Also, indication-specific breakpoints and species-specific, where for some breakpoints, it now is only for E. faecalis and not for all the enterococci. So if we start with the penicillins, as you can see, it's almost completely yellow. For ampicillin now, there's revised both MIC and zone diameter breakpoint. And when it comes to amoxicillin, previously the only was amoxicillin, and now it's stated IV or oral. And we might just remove this IV part since we don't use it in the Nordic countries. We'll see next year. So we have a breakpoint for IV, all indications, but then when it comes to oral amoxicillin, the breakpoints are only for uncomplicated UTI. If we have other indications, first of all, it's only for E. faecalis, and it's breakpoints in brackets with a wild type I. So that's new and probably will cause a little headache in your laboratories. And of course, the same is completely analog with the amoxicillin clavulanic acid. Now the clavulanic acid doesn't give any extra benefit, so it's only maybe if you're going to treat mixed infections where you need it, but it's the exact same there. And then last is that we now have breakpoint for piperacillin tazobactam. It's only for E. faecalis. But you may now test it on its own and no longer infer from the ampicillin. So that was the penicillins. When it comes to a couple of the other groups for imipenem, it now is the breakpoints are only for E. faecalis. And when it comes to the comment about the fluoroquinolones, it only, and the moxicillin, when it comes to the oral step down for endocarditis, this is also only for Enterococcus faecalis. And then we have vancomycin, and here there are now two rows. The one that we've always had kind of is unchanged when it comes to the breakpoints, but it's only for E. faecalis and E. faecium now. Then we have one row for all the other enterococci, except for Castelliflavus and Gallnarium, where you still shouldn't test the vancomycin, where the MIC breakpoint is the same, but the zone diameter is different. And then when it comes to the tetracyclines, now the tigercycline is different. Now we only have one row, and it's for all species, and adjusted the MIC breakpoint. Previously, Enterococcus faecium had a different zone diameter breakpoint, but now this is everything is put up in the same, so we don't have anything just for the E. faecium. So that's tigercycline. And then we already have, and then it's the enterococci and the trimethoprim and trimethoprim sulfametoxazole, where we have a specific comment. And now it looks it's all yellow, but the only thing that's changed is that we no longer have the ECOF as part of the wording. So otherwise, everything else is just like as used to be. So there's really nothing important change here. Then we're done with the enterococci. So now we go to the beta-hemolytic streptococci, where the penicillin MIC breakpoint now, or the breakpoints are quite adjusted, which means we no longer need the unique NordicAST comment that we've had the last few years that are in red, where we have a wording on how to screen for low-grade butylactam resistance. So we don't need it because now this new breakpoint will catch these isolates. So we now have two rows. We have one that's for A, C, and G, where the breakpoint is from 0.25 to 0.03. So it's quite a big change. And the same goes for the zone diameter, which is quite a big change. And then we have one row that's only for the group B streptococci, but it's all indications since it now is the same as the previous meningitis breakpoint for group B streptococci. So then you know that A, C, and G has one row, and GBS has a separate row, but all indications. Someone's talking.
Please remember muting everyone. Thank you.
And then rifampicin also has quite a change in the MIC breakpoint from 0.06 to 0.25. Okay, so that was the those streptococci. Now we go to the pneumococci, and here we had a seminar, online seminar on December 5th. So if you didn't attend the seminar, if you want details, I strongly recommend to go and look at that, because there you get all the details. So now I'll just give the very short overview. So the big difference is that we have a new breakpoint for the benzyl penicillin, and then we also have the screening flowchart has also been revised to make it easier for everyone and not have to do the benzyl penicillin MIC. So in short, you have to add a penicillin 1 unit disc from the start. You'll save time for the ones that aren't completely susceptible. And then I'll show you the revised flowchart. And it looks very revised since everything is yellow, but I've tried to point out where the big changes are. So in the beginning, the top part, you add a benzyl penicillin 1 unit from the start, which is only read if the oxacillin zone is less than 20 millimeters. When it comes to the two boxes on the left, the only thing that's changed there is that we've taken out the meningitis wording because we don't need it anymore. And when it comes to this right top box, here we've added endocarditis for the ones that you need to report resistance. And then in this box, the wording is new because here you use the benzyl penicillin 1 unit disc to see what you get. And if this is then susceptible increased dosing, then we put, and that's in red, since this is what we have in the NordicAST flowchart and not in the UCAST, that we recommend that you should consider adding a comment to the clinicians just to make sure that they remember to use high enough dosing. And the last box to the bottom right, it's mostly that the meningitis wording is omitted, and we just slightly rephrased that you test other beta-lactams, but you don't need to think about benzyl penicillin because that's already taken care of. So that was in short, and like I said, you should look at the webinar from December 5th if you didn't attend. So here is the breakpoint part where the R now goes from 2 to 1, and that's why it's had consequences also for dosing. And then we have just added new agents as IE, which is the cloxacillin, oxacillin, declox, and fluclox. And that's pretty much it for the pneumococci. So there's the benzyl penicillin, which is the big change. And then we go on to the virulence streptococci. And here also, since we now have specific endocarditis breakpoints, then we've removed that general note on having to refer to national guidelines for endocarditis. And Anna Karin slightly mentioned this now because we have some new rows. So the first one is benzyl penicillin indications other than endocarditis, where it's quite the same, except for also here our breakpoint is changed from 2 to 1. And then we have a row, now a separate row that's for endocarditis with unique breakpoints. And then we have a third row, and that's endocarditis in combination with other antimicrobial treatments. So there you have to have the breakpoints in brackets. So it's, yes. And then also we have an extra row that is if you use the ampicillin intravenous for endocarditis. And the ampicillin other indications, now we just added that for all other indications, and there you don't specify whether it's oral or intravenous. When it comes to amoxicillin, here also there's a separate line or row now that for endocarditis, where it's only amoxicillin intravenous, which we again might omit since we don't use it next year. And also a new comment that says if you have the benzyl penicillin screening negative, you can just use it to infer the amoxicillin, but if it's positive, then you have to test for the amoxicillin. And then here also these same agents are added as an IE. And also a new comment, and that is completely analog to the rifampicin and the moxifloxacin when it comes to oral step down for endocarditis, where you can use a MIC value of 2 to see whether we think it's resistance mechanisms or not, but you can't report it. You have to as SIR, of course. So that's also for linezolid. Okay, so that was for those gram positives. And now the next group where the only changes are for the Haemophilus, and I think maybe you would have been disappointed if there wasn't anything new on Haemophilus, because it always is, and then Kingella. So when it comes to the Haemophilus, here also we've added the endocarditis together with the meningitis. So that's why you have the new rows or the new, it looks like it's new, but it's just that we put in endocarditis with meningitis, but the breakpoints are completely the same. But one thing that's new is that you no longer need to test MIC test for cefotaxime or ceftriaxone for meningitis. So now the breakpoints are the same. They always were. So we just have breakpoints that are valid for all indications and also method. So when it comes to the flow chart, it's updated accordingly. And the only time we say that you need the MIC determination, that's for meropenem. So then, of course, also the comments about having to do MIC testing for meningitis in cefotaxime and ceftriaxone is removed. Another change is the ciprofloxacin, where we used to have 2 rows, but now the MIC breakpoint was changed from 0.06 to 0.03. And then leaves that the breakpoint is valid for all indications. And here's the new flow chart. When it comes to the 2 left yellow boxes, the only thing new is that we've omitted the meningitis wording. And when it comes to the upper right yellow box, we specify that is for meropenem and meningitis that you need to do the MIC. So this should also be easier than previously. And the only thing with Kingella is that we now have its own diameter breakpoint for amoxicillin clavulanic acid, which is then included with comments saying that you can use this diffusion, but there is no MIC method since it often gives you too low or falsely low MIC values. But it's good that we have a breakpoint. Okay, I think I've talked enough. So now, Heikki.
Okay, so here are the last species, and for most of these, there are nothing new to report, which you can see in the next slide if you change to the next one, please. Here, yes, so for most, there is nothing new to report in the NordicAST table, but when we go to the next slide, you can see that Moraxella cataralis has some new changes, but actually these were covered in the general section of this presentation. So I think we can skip to the anaerobes here, where are very minor changes here. So first of all, in the general section of anaerobic bacteria, the incubation time for agar dilution was updated because there was a minor typo in previous versions of the tables. And as you can see here in the left, the incubation time was 48 hours strictly, but actually the incubation time is not that strict, so it was updated to be from 42 hours to 48 hours. And the MIC breakpoint for Fusobacterium necrophorum and penzyl penicillin was changed a little bit from 0.06 to 0.125. And lastly, the Bacteroides species and Piperacillin tazobactam got a new comment, which tells you that the species that are susceptible to ampicillin sulbactam and amoxicillin clavulanic acid can be resistant to Piperacillin tazobactam. And I think that was all from these last bugs. Thank you.
Thank you. And Barbara, do you want to say something?
Yes, I would love to. So before we go over to the questions, which you already have written many in the chat, just save the date. You know that we have the annual workshop, and it will be held this year, the 27th to the 28th of May, again in Malmö Hyllie, again at the same hotel as last year. The plan is to have a preliminary program and the registration link ready for you from mid-February, and we'll announce that both, of course, at the website and also through our national networks. Just to draw your attention to that, we will have again a mini oral presentation session as we did last year. So if you're a lab technician, bioengineer, a microbiologist in training, or a PhD student, you can, at the registration, send an abstract, and if that is accepted, you can present your work at this mini oral presentation session and register for the workshop at a reduced fee. But we will have more information on that available at the website when the registration opens. That was all from me for now.
Thank you. Okay, so then I guess what's left are questions, and in red, this is the breakpoint people, and in blue are our extra people helping answering questions. So I think I'll just leave it to you, Christian.
Yes, thank you. I think some of them will be assigned to Erica as well. But I can start, since I didn't have the pleasure of having a presentation. I can instead enjoy myself with the questions. Many of them which are really questions to UCAST rather than to NordicAST. And maybe we should remind that the main purpose of this session is to explain what's new in the table and not really go through all of the justifications for UCAST decisions. However, since I'm an extremely nice and very patient individual, I will go through the justification as well. But this is just to explain briefly that the main scope of this seminar is not really to explain about all the consultations during the year where things were explained about the justification for those changes. So that's mostly questions that should be directed to UCAST, and this is always possible to email UCAST, for instance, the scientific secretary, to send questions and comments. And of course, you are always encouraged to respond to consultations, which is something which is a very good thing to do. To be able to capture your maybe important comments at an early stage before the final decisions are taken about the breakpoints. All right, with that long introduction, I will start from the top. Can ECOF be shown in the breakpoint table for the note antibiotics? Potentially, yes, but there are some problems with this, and one of them is that the ECOFs can still sometimes be revised, and this can lead to a discord between what is in the MIC distribution website and what is in the table. And it's quite challenging to maintain this, and maybe later on the breakpoint group would like to comment on that. But in order to be sure that you have the most recent version of the ECOF, the best thing is always to go to the website for the MIC distributions. Then you will be sure that no one has been revising the ECOFs based on some new analysis. And Erica wants to comment on this as well.
Thank you. Yeah, I just wanted to add that sometimes when we are talking about a group of organisms like Enterobacterales or Enterococcus species or virulence group Streptococci, then we usually add a cutoff value to the breakpoint table because the ECOFs are for individual species. But we try to avoid having the ECOFs in the table if they are in the database, because it's also very difficult for us to keep it updated. And as Christian said, they might change over a year if we get more data.
Very well. So that was the first question. Only something like 10 to go or whatever it is. What is the rationale behind the changes for piperacillin tazobactam regarding Enterococcus faecalis? And then there is a follow-up B with some comments on the MIC distributions. And these two are really quite connected. So the rationale for the changes of the piptazo breakpoint, which was in a consultation, is as alluded to here, that the ECOF is 16, And covering 16 with a decent time above MIC is not possible with a normal exposure, and hence it follows that logically it should be increased exposure for this situation. Of course, there are many situations where this would probably work still fine to go with the normal dosing regimen, for instance, in mixed infections where you anyway do not necessarily need to cover everything perfectly, like polymicrobial infections related to intra-abdominal infections where you also had surgery. Then, of course, if there is a clinical response and there happens to be enterococci and you had a response on 3 times daily, then I'm sure you don't need to get very worried or worked up about it. But if you have a severe enterococcal infection and you want to treat it properly, then our advice is definitely to go for the high exposure, which gives you the best coverage of the whole wild type. About the question about piperacillin, we are not really aware that lots of people have in recent years tested piperacillin to a large extent. So these data are perhaps a bit older from the time when Piptazo was not available. I have specifically asked the curator of the MIC database to look further into this. It's, as you see, a discrepancy between Piptazo and piperacillin. However, that should be analyzed and maybe also looking at the individual MIC distributions to see if there are some signals. And piperacillin is not really used a lot anymore, and it might also be that there could be some things here at play. But I would say mostly the Piptazo data are probably of more recent date. And the question is if they are more reliable. We don't know that for sure, but our assumption in this process has been that the Piptazo data has been very recently curated, and that the curators of the database feel confident that the true ECOV for E. faecalis is 16. Do we have clinical data supporting that the standard dose of piperacillin tazobactam is insufficient for treating Enterococcus faecalis? Well, as probably most people are aware of, such data very rarely exist. And if there are data with some failures, there are so many caveats, such as people not testing with appropriate MIC methods. And there can be also so many different confounders. And of course, that would have to be also situations with monomicrobial infections. Otherwise, it would be really difficult to make such assumptions. I think it would be really difficult to find an appropriate data set to answer that question with clinical data. And unfortunately, that is true very oftentimes in our field. And as we know, there are so many other factors that make clinical data difficult to interpret. Erika, did you want to comment on that?
Not exactly on that, but since you mentioned testing with different methods, I just wanted to comment that as far as I know, the piperacillin tazobactam gradient tests have never been validated for enterococci. So I think that's important to know.
Yeah.
So from our perspective, you should either use disk diffusion or broth microdilution.
Yeah. All right. And in any case, such failures would probably only occur in those really severe enterococcal infections and not in the type of mixed polymicrobial infection intra-abdominally where you already had surgery. Have you considered dividing a recommendation for Piptazo into uncomplicated UTI only and other indications? Well, I don't think we have considered that for one reason, because Piptazo is not really used in uncomplicated UTI. This may be one side of that. And the other is that the high exposure also means that you can use it in not only if you increase it to 4 dosing, but also if it's concentrated in the urine, you can also use it. So that's what in practice that means, but we did not consider adding uncomplicated UTI. Then you would need to do that for all IV agents, and I think that would be a bit also maybe pushing it since it's not really common to use these agents in uncomplicated UTI, although you can never exclude that it would absolutely never happen. Barbara, did you want to comment anything more on this?
Yeah, I agree that it's not relevant with the uncomplicated UTI only breakpoint, but I think we could consider, or UCAS could consider a breakpoint for infections originating in the UTI, in the urinary tract. That could be relevant, but I agree not for uncomplicated UTIs. Because that would make it easier to report fecalis isolates as for urinary tract isolates.
Yeah, well, but it would also pertain to potentially other situations in the table. So it would be, I think, a bit random to fix that for fecalis, because there could be other situations where we also have ice, and it could be like this, and that just needs to be considered for logical consistency across all the tabs. But that's anyway a question for UCAST more than anything else. And then there is a question: is there a discrepancy between the UCAST and NordicAST tables regarding amoxiclav and Enterobacterales? Yes, there is. So it is correct in the NordicAST version, and it's wrong in the UCAST version. That's the short story of that. Basically, it's a very bad idea to try to treat Enterobacter cloacae or something with amoxicillin clavulanic acid, and UCAST has not come around to fix that since it requires a consultation, and it hasn't been a very strong priority. But if people are very disturbed by this, then I may consider see what I can do to limit the number of species, which we have done in many other places, but not in this specific situation with amoxicillin clavulanic acid. So, but certainly this would be a very strong both inducer of AMP-C, and it would additionally lead to selection of hyperproducing AMP-C. So it's a bad idea to try and treat Enterobacter cloacae, Morganella, etc. with amoxicillin clavulanic acid. So that's basically better to follow there the NordicAST table. The next question, for those who are now a little bit fed up with hearing my voice, I will hand over to Erica. It's about explaining in a little bit more detail the rationale behind the changes of disk diffusion breakpoints for benzyl penicillin to 2323 for hemolytic streptococci A, C, and G. So that's the question.
Yes. So in previous years, the MIC breakpoints for Streptococcus A, C, G, and benzyl penicillin was less than or equal to 0.25. And now it has been changed all the way down to the ECOF, which is 0.03 milligrams per liter. And as you all know, for many years, we haven't detected resistance to benzyl penicillins in group ACG streptococci. We know that it might occur sometimes in group B streptococci. But there are some reports there are isolates with slightly elevated MICs. So UCAST has now decided that it's better to have a breakpoint that is based on the ECOF, because that is the only way that we can detect resistant isolates. And then we follow with a zone diameter breakpoint, of course. And if you have a zone below 23 millimeters, it's probably method related. Maybe how the plate was streaked actually quite often affects the zone edge appearance. It might be difficult to read the zone if you don't have a very even lawn of growth over the plate. And of course, sometimes it might be a fuzzy zone edge. So whenever you have a zone less than 23 millimeters for a group ACG streptococci, you should definitely repeat the AST and the species identification, and that is already listed in the NordicAST tables. And for many years, we have had this comment in the NordicAST table, but it has not been in the UCAST table that you can use the cutoff of 23 millimeters to possibly detect resistance. So that is the background for the change.
All right.
Maybe I could take the dalbavancin question also,
Yeah,
and
please,
then you can
please
go
do
back
that
to
also. Yeah.
reporting of breakpoints in brackets. So dalbavancin, there are some reports showing that isolates staphylococci and coagulase negative staphylococci can be susceptible to vancomycin, but they can be resistant to dalbavancin. The most likely explanation for that is that dalbavancin is more similar to teicoplanin than to vancomycin in the structure of the molecule, and therefore it's not 100% sure that vancomycin susceptibility can be used to infer dalbavancin. So therefore the comments were removed in the Staphylococcus table. In the Enterococcus table, we don't have breakpoints for dalbavancin, but there are ECOFs, and those were set during last year when we had more data and we were able to establish ECOFs for Enterococcus faecalis and Enterococcus faecium. And there is also a comment in the expert rules that if they are vancomycin susceptible, they are wild type to dalbavancin. They cannot be reported susceptible since there are no clinical breakpoints. As far as we know, that is still true for enterococci. And as you know, Van B producing enterococci usually are vancomycin resistant, but teicoplanin susceptible. And as far as we know, they are also wild type to enterococci. But this comment in the expert rules is also now under discussion, and it might be revised in the upcoming revision if we can find the same proof for enterococci.
Yeah, at least I agree with Linnea, who asked the question that if it's IE in the table, then the expert rules shouldn't say reported as susceptible.
Well, yes, maybe that was the question. That is totally correct.
Yeah.
So that should be corrected in the expert rules,
Exactly.
regardless, that they can be they can be considered wild type, but they should not be reported.
Exactly. So it should be reworded. I think this is a very fair point, and we will check that this message is transmitted onwards to those who are responsible for the expert rule revisions. Then we come back to a question about breakpoints, and this question is about viridins and benzyl penicillin, and it pertains to this specific scenario when you were in the old I group, which we removed, but we made brackets around it to show clearly that you need to use, if you are above the ECOF, you need to use the compound in combination. I agree here that maybe it was a mistake that we didn't clarify that it's also an I group, but in a way you could say that endocarditis is always high dose. And when you treat endocarditis, that's something you should be aware of. So I would, in this specific situation, say maybe that it's not needed to have an I. It's a little bit like meningitis, even though you need to use high dose always. We don't flag that by using an I. Rather, you should, as a treating clinician, know that when you treat endocarditis, you always need to use benzyl penicillin at the endocarditis dose. And then if you are in what was the old I group, which is above the ECOF but below the R breakpoint, then you need to add another agent. So that's really what it means. But I don't think this should lead to misunderstandings, because people are already aware that they should use endocarditis dose. And of course, if the MIC is higher, then you shouldn't lower the dose. So that would not make sense. So I think this part is probably fine, although there can always be some confusion about the clearest way of presenting the data. And then we have another one, Streptococcus pneumonia. Are there good clinical data to support that 3 gram times 4 is insufficient despite the Monte Carlo simulation? And no, there is very crappy clinical data, so the clinical data cannot be used to support basically anything other than saying that the wild type is treatable and that usually the I group is probably okay, but you cannot exactly say on grounds of clinical data where to put the R breakpoint. And of course, as always, there will be many examples that patient who get 3 gram times 4 will respond to infections. So this is not like a magical thing that it will always be a response or never be a response, but it's rather that we want, if you want your patient to have to be certain that the patient has an adequate exposure, then you need to dose it 6 times daily. But clinical data are usually, as I said before, quite absent when they exist. It's usually with very bad MIC data, and it's all really not extremely informative, for which reason we also need to consider quite a lot of PKPD. Of course, we would have wanted to see high quality clinical data. This is always what we're looking for, but this is sometimes a great paucity of such data, and that is definitely a key problem. Finally, we have about reports to the clinician. The recommendation for breakpoints in brackets is to add a comment and not use SIR. I do understand the reason, but won't it be better to recommend not use SI or R alone for better readability? SIR in bracket in the antibiogram would be preferred, but not possible in many LIS. However, presentation should evolve as technology evolve. Comments tend to be too many in reports. I fully agree with Magnus that the best would be to encourage the developers of LIS systems that they in fact try to make it possible to use brackets. I mean, this would be a very nice feature, and if this is possible in the future, then I definitely agree that this would increase the clarity of the presentation. And then it could also come as a footnote, as you suggest in the further comment. So I think those are good suggestions, and I think we would really like to see that, or at least I would like to see that. But as you point out, it's a problem that this is flexibility doesn't really exist, unfortunately. Barbara.
Yeah, just a comment on these comments. I think that is very complicated, and it really is about that you, in your local lab, know what kind of contact you have with your clinicians, how the communication is done. Usually, whether you have, for example, for blood isolates, you always have a direct communication, and then you would do things differently than if you don't. So I think this is really about to individualize how you can use comments. I totally agree. It's easier said than done to have good comments and to have comments which in all LIS systems are read by all clinicians. So that is definitely it's not easy to handle, and I think often you have to find a solution which is the right one for your local setup.
Indeed, and with this, I think we may have exhausted the questions for the time being. So this might mean that I hand it back to you, Karianne, if you want to close the session, or if anyone want to say something.
I could just add something.
Yes, please.
If we go back to the gram negatives about just to inform you about Asterianum avibactam. So at the National Reference Laboratory for Phenotypic AST in Karlskrona and Växjö, we can test for Asterianum avibactam. It will be included in our extended gram-negative panel, but we have just received it actually, but we have to validate it first. But we do have panels with Asterianum avibactam, so if you want to have a report for that, please add it at the referral form, and it will be tested on the first day when we perform broth microdilution. So, but further on, it will be always included in the extended gram-negative panel.
That's very good.
Thank you.
And it doesn't seem like there are more questions at the moment, but of course you are more than welcome to send questions. And it's good to think that if there are questions which pertain to more general things that are more UCAST questions, then you can also direct them to UCAST directly. So this is dealt with immediately by the UCAST system. And don't forget about the public consultations, where you have a chance to ask some of the questions that you asked here.
Great. So I want to say thank you for everyone that's been listening, and to Erica and Christian for helping out, and for Barbara for being there, and of course Heikki and Anna-Karin that were with me here today from the breakpoint table. So with that, have a wonderful day.
Thank you. Bye-bye.
Breakpoints, yeah.